Hi, everyone. My name is Jade Nunez. I'm one of the trauma surgeons here at the U. I work with Dr. Price in Mongolia and with the Center for Global Surgery. Dr. Benson and Dr. Price, thank you for having me. Again, I'll be speaking on the Lancet Commission for Global Surgery's indicators. I've had quite a bit of experience collecting those in Mongolia, which I'll discuss further. So as an overview, we'll discuss what brought global health to global surgery, um, what the Lancet Commission on Global Surgery is, as well as the surgical indicators and their collection in Mongolia and what we found, and we'll touch on INSOAPs as well. I won't belabor these points too much because you are in a global surgery and public health course. I'm sure you've gone over most of it, but just as a 10,000-foot view, global health historically has been focused on infectious disease, and that makes sense because those are large public health measures that can solve big problems with rather common sense solutions, which evolved into other interventions like vaccines and have done the world so much good. So when you think of global health, you tend to think of HIV, tuberculosis, and malaria. And historically, global health has been focused on individual diseases and has neglected the integration of health services and systems up until the latter part of this century or the last century. And surgical care has been a low priority. And when you think about why that might be, it's because surgical care is complex. This is what it takes to safely and efficiently do surgery on someone. It takes the patient at the center, surrounded by a surgeon, anesthesia, nurses, technician, equipment, a building, a hospital infrastructure, pre-op and post-op settings, and then everything that keeps that building going. One step out, you look at these higher level hospitals, what we're in here at the U. Those are fed by district level hospitals, which are really sort of front lines, down to primary health centers and referral systems down through the community. And even further out than that, maybe a 30,000-foot view, you have professional societies, the WHO, NGOs, and advocacy organizations. In every country of the world, it takes a huge ecosystem to deliver safe surgery. And so, looking back on the course of global health, surgery really hasn't been prioritized. Dr. Paul Farmer and Dr. Jim Kim describe global surgery as the neglected stepchild of global health. And they, along with the surgical community, address some of these common myths of what surgery is and why it's not appropriate for global health. Things like surgery is too expensive. It can only address a small problem. It may only offer short-term relief, and we all know those to be false. Surgery is expensive because of all the things we just talked about, it being a giant system, but it should be viewed as an investment in a nation and in the world. Surgery does not only address a small problem. It's not like it only fixes a hernia. Well, that small problem to that person who has the hernia, it means they can't work. And so suddenly, if we fix the hernia, they're added, many dailies to their life. Furthermore, surgery is indispensable to the rest of the medical system. 65% of all cancers are treated with surgery. Surgery does not only offer short-term relief, it really intervenes it can be in a bad part of someone's life, or it can solve a major problem that's impairing them. These are all things you know. When we think about how successful global health has been and in decreasing communicable disease, there's been this epidemiological transition as nations have become more industrialized. And so hygiene's improved, systems have improved, and communicable disease has decreased, and non-communicable diseases um, have increased along the way. And all these things are potentially treated by surgery. Um, there's the HIV, AIDS, TB, and malaria, but when you compare them to a surgical disease, I should say one surgical disease, which is injury or trauma, it's dwarfed by the death per year. About 5.8 million deaths per year from trauma and injury, and somewhere in the mid fours for HIV, TB, and malaria combined. And so, as global surgery has gained momentum for these reasons, it's been recognized and championed. It gained official footing with the WHO with the establishment of their Global Initiative on Emergency and Essential Surgical Care program. And this was the first time there was really a large-scale public health, primary health care initiative that involved surgery. 2015 was a big year for global surgery. The disease control priorities published a whole book on just essential surgery. The G4 Alliance was established, which is there to promote SOTA care, SOTA, surgical, obstetric, trauma, and anesthesia care. The World Health Assembly famously declared Resolution 6815 on strengthening emergency and essential surgical care in anesthesia in the context of universal health coverage. And then finally, the Lancet Commission on Global Surgery was established and brought people together from all over the world in 4 working groups to make a case for global surgery, to provide an update on where surgery stands worldwide, and to really make an evidence-based case for what should happen next. And that brings us here to what we're talking about today. There were 4 working groups involved in the commission: healthcare delivery and management, workforce training and education, economics and finance, and information management. And so the sort of 5 banners they wave, there are 5 key takeaways, which you've heard before in this course undoubtedly. The world's population consists of 5 billion people who don't have access to safe and affordable surgical and anesthesia care. There are 143 million additional surgical procedures needed in LMICs each year. There are 33 million people in the world facing catastrophic expenditures when faced with paying for surgery. And investing in surgery is affordable, it saves lives, and it promotes economic growth, as well as being an indispensable part of healthcare. So these are the 6 Lancet's surgical indicators. Why do we have them? It's to get a baseline for a country, to be a thorough assessment of needs, but still at this sort of 10,000 foot view that would then feed into national surgical planning. And so those are sort of broadly divided into preparedness, service delivery, and cost protection. Under preparedness is 2-hour access to essential surgery, surgical workforce density. Under service delivery, there's surgical volume per 100,000 population. There's perioperative mortality. Under cost protection, there's impoverishing and catastrophic expenditure. I should say impoverishing expenditure will probably be dropped after a series of meetings. There are targets for each, and there are reasons behind each target. So for access to timely essential surgery, they'd like a minimum of 80% coverage of essential surgical and anesthesia services by 2030. For workforce density, they want every country to have at least 20 SAO providers per 100,000 population. For surgical volume, they'd like 80% of countries by 2020 and 100% by 2030 to at least be tracking surgical volume. They have a minimum of 5,000 procedures per 100,000 population. for perioperative mortality, like 80% of countries by 2020 and all of them by 2030 to be tracking periop mortality and to be setting targets now. And then for impoverishing and catastrophic expenditure, they would like 100% protection from out-of-pocket payments that would cause catastrophic or impoverishing expenditure. Those are ambitious goals, as you'll see. This is a chart put out by the Lancet Commission, or an illustration. The darker the red in the country, the greater proportion of the population is without access to surgery. So what is access to care? Is it just being able to walk into a hospital and get surgery? Sort of, but not quite. You need to reach it in a timely manner. The hospital that you reach to get that emergency or essential surgery needs to have the capacity to perform the surgery. It has to be safe. It has to be affordable. Why does it have to be affordable? Aren't you going to pay whatever to stay alive? Well, you might not. If you know that you getting surgery to fix your hernia or your appendicitis is going to starve your family, then you're probably going to stay away. And so if someone can obtain surgery without catastrophic expenditure, then they have access. And so all of these 6 indicators really go into what access is. I should say, because all 6 go in, they're all reliant on each other. You can't just hang your hat on one indicator. It takes all 6 or 5 looked at as a whole, and they speak to each other. And going back, sort of this first level hospital, where'd you go? Oh, well. That first level hospital is really the point of the spear for getting access to people. It's the most cost-effective platform. By using first level hospitals appropriately, they're potentially $10 to $220 for dailies averted. And there are WHA programs that can define optimal structural needs, the GSEEC program, and there's something called the Essential Trauma Care Project that can help evaluate district level hospitals. Mongolia was included as part of the Lancet's assessment. This is from probably 5 or 6 years ago. The red is, I should say, blue is 1 hour access, and the yellow or white is 2 hour access, and that covers 80% of the population. We'll dig into that a bit later. The second indicator, surgical workforce density, captures workforce availability. You can stratify that by location or place of work, and disaggregate it by physicians versus other providers, specialists, or they're licensed, who owns the facility. The goal being 20 specialists per 100,000 population, because less than 20 SAO correlates with a decrease in maternal survival. But when it comes down to it, an individual country should define their own ideal density. Surgical volume as a target, as we discussed before, and you sort of encounter caveats. You start seeing that C-sections are perhaps overdone in some regions. Mongolia has its own twist on this. High-risk patients or complex procedures might not be performed because of a lack of resources or consequences of poor outcomes. It is the most widely reported indicator because it's the most widely collected at baseline. Perioperative mortality. So ideally, we would all be tracking 30-day mortality. Unfortunately, it is impractical in most of the world. And so number of in-hospital post-op deaths from any cause are more easily obtained, and that's our standard. Risk adjustment is a future goal in collection. As far as the economic evaluation of essential surgery, it's worth mentioning here, just stepping away from the indicators. At one point, there are multiple ways to evaluate the impact of surgery economically. You can look at specific health outcomes, like how many traffic accidents can be averted with a public health measure. You can look at the aggregate measure of health, which I'm sure you've discussed with Dollies and Qualies. Financial risk protection, which is the actual indicator, and make arguments for the economic benefits of surgery, which is what the Lancet Commission did, looking at dollies averted or dollar per dolly averted. The financial argument here is that many forms of surgery are actually more cost effective when looked in this framework than common public health initiatives like aspirin or beta blockers for ischemic heart disease, or even antiretroviral therapy for HIV. Vaccines being very cost effective. Further, they took a VLO approach, value loss outcome, I believe. Correct me, please. They looked at annual and cumulative gross domestic product losses secondary to surgical diseases, basically showing the economic burden of lost output, and showed that this burden is increasing as time goes on, and will increase through 2030, and that LMICs will be bearing the heaviest burden. And so it really is an urgent investment that needs to be made in infrastructure. So they made a nice argument that surgery is cost effective. But we still have that number of 33 million facing catastrophic health expenditure. So impoverishing expenditure is financial access to and effective seeking care. So it's the proportion of households protected against impoverishment from direct out-of-pocket payments. Essentially, you're being pushed into poverty because you're seeking surgery. Catastrophic expenditure, on the other hand, is a bit different. You may not be pushed into impoverishment, but it takes up 40% or greater of your household income. So it's a huge impact, and by this measure, upper class and middle class families, or I should say upper and middle quartiles or quintiles, are affected sometimes to a greater extent than the poor. That one kind of slid in. So in Mongolia, we were asked to help them collect their indicators so that they could formulate their national surgical obstetric and anesthesia plan. We were at a advantage in Mongolia because they're structured top down, and or from their Soviet days are quite good at collecting things. Every district level hospital, every provincial level hospital has a statistician that reports directly back to the capital. Even with those advantages, getting these in a nice tidy package were not easily done. It took a while. So indicator 1, 2-hour access, what do we find? Very similar to what the Lancet's team found. There was an 80% coverage of 2-hour access, or the population who had a 2-hour access to surgery. But what does that mean when you look closer? Well, the thing you have to know about Mongolia is that it's a very vast and sparsely populated country of 3 million people. 1.5 million people live in the capital here of Ulaanbaatar. And so they have 100% access of half the population because they all live in one city. Also, basically all of their quaternary hospitals are in that capital. When you look outside the capital, immediately outside the city limits, that coverage drops to 60%. And though it's a country that's historically nomadic, they're semi-nomadic, and they tend to roam around these city areas, which accounts for that 60%. So we were able to make recommendations by modeling this out a bit. Instead of recommending that they upscale every single regional or district level hospital to have essential surgical capacity. We thought it was more realistic to suggest 5 district hospitals in sort of key areas or the most populous areas, and that's would bump up their access by a few percentage points. In addition, we sort of wondered what would happen if they added 5 new hospitals in particularly populated areas, and that would add about the same amount. Surgical workforce density, indicator number 2, they seem to be doing quite well. Overall, there's a 47.4 number of SAO per 100,000 population. Heck, even obstetricians surpassed the baseline of 20. So they must be doing quite well, right? Well, not quite. When you look a little closer, a lot of them are obstetricians, and half obstetricians don't perform C-sections. They're just non-surgical obstetricians, and they end up having to commute. So even though a hospital may purport to perform C-sections, once you get there, they still have to wait for the OB to arrive from a certain number of kilometers away, potentially 100. And then we decided to look further at distribution. We did little pie charts in different locations. The red being obstetricians, blue anesthesiologists, and yellow were surgeons. A lot of these little areas, they only have an obstetrician, or they only have a surgeon, an obstetrician, but no anesthesiologist, so they don't exactly have capacity. Surgical volume, indicator number 3. They were under the threshold of 5,000 procedures per 100,000 population, and then something happened in 2014, and they bumped above. Well, we look a little closer. They switched from ICD-10 coding back to ICD-9 because it was easier, and they ended up capturing more outpatient procedures. So what do you do with that? Let's see. Yeah, surgical volume was also only above the threshold in UB, so that it speaks to most, or UB is about for the capital, most surgeries being performed in the capital, and no other province came above the 5,000 threshold. So UB is really propping up the rest of the country, and even they weren't that far above 5,000. Similarly, perioperative mortality plummeted in 2013-14 because of that coding switch. Naturally, if you add more outpatient procedures, then your mortality will plummet. Other points to make on perioperative mortality: these numbers are in line with middle-income countries, and or I should say, upper middle-income countries. Mongolia is a lower middle-income country. Flirts with middle every once in a while, depending on how the economy and mining is doing. So these are kind of okay numbers, but still it's buoyed by UB. And when you start looking at individual regions or provinces, actually a good portion, dozens of them, are not reporting mortality or any mortality at all. So you start to ask yourself why. Well, one reason could be that most cases or complex cases are referred to the capital, which in some parts of the country, this country is as big as the Western U.S. Some parts of the country that takes 12, 15, 16 hours to get to UB. And then the other reason being that there's not a culture of quality improvement. There are legal ramifications for surgical misadventures. So if you have a complication, you could be put on trial and put in jail, and your name will make the news. And so you're probably not going to report a lot of these mortalities. That leads to a whole other discussion. Impoverishing expenditure and catastrophic expenditure were also interesting. Mongolia does have universal coverage, not technically universal universal health care. They are all covered, but there are still out-of-pocket payments. There are no formal out-of-pocket payments for things like a laparotomy or a C-section. However, you do pay. There are some more formal out-of-pocket costs for a lap chole or technological procedures. So, laparoscopy is one, and then femur involves hardware. That's more expensive, and so there's some out-of-pocket costs there. Um, and so you can see this trend over time. In 2012, there was some legislation that allowed uh, orthopedic hardware to be better covered. At the same time, the cost of lap choles and lap appies and the like are just skyrocketing. Similar for catastrophic expenditure. That drop in cost in 2013-14 due to that legislation and the slow creep up of laparoscopy. And so this exercise, I think, was very telling. It was very interesting. It's led me to a lot more questions. What's next? I would love to start characterizing access delays in a country like Mongolia. They have a sort of a healthy. There is a an interstate system, I suppose, but there's only a few roads, and so a lot of it's just dirt roads that have been made over time. And if that road goes through a river, and um, it's dry, then you can pass. If it's not dry, if there's flooding in spring, say, you're stuck, and maybe you're camping there for a couple of days. One of my one of my colleagues was stuck there for a whole weekend, and just bought a goat off a farmer and had a barbecue and camped that weekend until the river got low enough to pass. In the winter, obviously, it's extremely harsh, um, and you're not going to, or 2 hour access is not going to look the same. That said, there are parts where you can actually drive over a iced over river or an iced over lake and get somewhere potentially faster. So I think I find that question fascinating, especially in a country whose climate is as harsh as Mongolia. At the same time, I know that not everyone in the capital city is getting essential surgery within 2 hours of needing it, because I've been in traffic in that city and it's horrendous. And furthermore, the referral patterns, we're told, are not efficient. If you live just outside the capital, you may be referred to have your baby or your scheduled C-section somewhere in the middle of the capital, and so that'll take you potentially 4 or 5 hours. What does it take to engender trust in the health system? So they have a big problem with surgical tourism. If you need a procedure and you have enough money, then you're going to consider going to Japan or Korea, sometimes India or China, to get your procedure done. It's going to take improved training, research, and some international outreach to improve quality and improve their perception. And that's just what our colleagues are doing. They have been able to establish a robust liver transplant program in a country with a very high burden of hepatitis B. So in a region with very high liver failure, they are the highest. And so they performed their 100th liver transplant last year. They partnered with Japanese, or excuse me, Korean surgeons, with a very unique training model. That's really fascinating. And they've done a really great job. We need to help promote a culture of quality improvement so that so that surgeons aren't scared to report mortality. That complications can be discussed freely, and surgeons are not at risk of going to jail for a complication. And then I would love to characterize informal out-of-pocket payments. What does it mean to have universal coverage, but you're still having to pay, you could argue, a bribe to your surgeon or a tip, depending on how and how kind you're being. Um, what's that look like? And in some places that might be, richer patients paying more, and poorer patients paying nothing, or it might be just a standard under the table payment of what's accepted for various reasons. But um, there is the burden of catastrophic expenditure is probably higher than we think. To round out, what is an INSOAP? It's a National Surgical Obstetric and Anesthesia Plan, and it takes quite a doing. So you start with analyzing these baseline indicators. You have to muster up local champions, broad stakeholder analysis and engagement. You have to build consensus and come up with ideas on how to address these problems you've discovered. Refine the language so that everyone's on the same page. Define costing, disseminate your ideas, and gain more broad support and implement these actions. And that spans from service delivery, human resources, infrastructure, information management, finance, and the government. So thank you guys for being flexible, allowing me to record this. I think it's 7 o'clock. We're going to get together on Zoom, and I'll answer any questions and discuss further. Thank you.